Good evening, members of the profession. Good evening, senior respected members of the Pharmaceutical Society of Kenya. Good evening, uh, other healthcare allied professionals. And good evening to the pharmaceutical technologists, medical doctors, and the seniors in the profession. Uh, Karibuni sana, ladies and gentlemen, to today's webinar on ongoing contraceptive care and counseling, which has been hosted in partnership between Pharmaceutical Society of Kenya and Maristops Maristops. Ladies and gentlemen, if you can hear me, let me know where you are from. Where you're joining us from. If you can hear me, kindly on the chat box. Let me know where you're joining us from. I want to start our webinar today once we get to minimum 150 attendees. Let me know where you're joining us from kindly. Dr. Tom Sindani, I know you're joining us from Kakamega, but let me know it's from Kakamega. Probably today you're in Nairobi, Daktari. And welcome all members to this wonderful webinar. If you can hear me kindly on your chat box, let me know where you're joining us from, tafadhali. Dr. Shital Shah is joining us from the Eldoret, Catherine Joroge from Nairobi County in Utawala. Asante Daktari, and hope you're all keeping safe. Dr. Bina Patel, Jambo from Nairobi. Karibu sana Daktari. Asante sana from also Nairobi. Ladies and gentlemen, senior members of the profession, Dr. Othiambo Agulo from Homa Bay, Dr. Nelisha Gwaral from Eldoret, Dr. Aisha from Nairobi, Ben from Kijabe, Jorodi Nyamoita. The reason to why I do this is at least to have and ensure that members from all over the country are able to attend our webinars. We're having Stanley Kiplotong from Nakuru, Dr. Ruperia from Nairobi. Asante sana Daktari from joining in. I can see Daniel Joe from Kisii and Stephen Wando, Dr. Kirugumi from Narok. Karibu sana Daktari. Dr. Netia all the way from Bungoma. Asante sana Daktari for making time to join us this evening. Asante sana Daktari for making time to join us this evening. Peter Owino from Kisii. Asante sana Dr. Peter. We always see you on our social media sites, very active. Asante, Dr. Dorothy Nyambega. We're only waiting for that only one attendee so that we begin our webinar today evening. Ladies and gentlemen, welcome all to today's webinar. It is part three of reproductive health needs that we have been conducting for the last 2 weeks. Today we have come to our final day. Lilo wanasema kwamba lilo na mwanzo lazima liwe na mwisho. Today is our last day on reproductive health needs, but it is not going to be our final. It is not going to be our final webinar on this. For members' demands, you're going to be able to have these webinars frequently and oftenly. So, ladies and gentlemen, it is conducted by PSK and from Maristops, Kenya, in courtesy of Maristops, Kenya. And today we're going to begins at 7 p.m. We'll go through a few ground rules before I begin. All participants are muted during the entire course of the webinar. Okay, we also request you to ask questions via the Q&A tab at the bottom of your window. For those who've been able to use the chat box, the Q&A tab is right next to the chat box. So I request you to use that. Also, PSK members, if not already done so, please subscribe on PPB portal for today's webinar so that you can get your CPD points. I will overemphasize on this. We have had a conversation with PPP and they have said if you miss a webinar and because you never subscribe, it is not to us. We can no longer award your point, neither can PPB award your point. You have to subscribe on the PPB portal. Kindly, ladies and gentlemen, ensure that you subscribe. It's just going on your PPB portal and hitting a button, just the subscribe button for that, so that you can get your CPD points. For KPA members and other cadres, the attendance list will be forwarded on request to your officials for awarding of CPD points. A point to note, CPD points will only be awarded to paid up members. These I will emphasize it and mention to our members. Kindly, ladies and gentlemen, for PSK members, you cannot even live with your own house bila kuweza nyumba yako ikiwa na magugu. Lazima pia utoe haya ujaribu kutoa magugu so that your home can look beautiful. So it is a request to all our members of PSK. Yes, it has been a tough year for us, but it is a humble request. Let us pay up our 2020 membership so that we go with a clean slate to 2021. For those who have been looking at the memes, we are having a meme going around showing that 2020 was isolation and masking, but next year is a matter of, and we are hopeful, it's a matter of the vaccine. So let's go with a fresh mind to 2021. Kindly, ladies and gentlemen, adhere and please ensure that you pay up your 2020 membership. The WIS webinar is being recorded and shall be made available hereafter on PSK's YouTube page. I am your moderator. My name is Mbao Getao, the communications lead at the Pharmaceutical Society of Kenya. It's already 7 p.m. We're almost done with introductions. I'm headed to our panelists for today. Our first speaker for today is none other than Dr. Michael Mungoma. He's a member of the Pharmaceutical Society. He's also a member of the Toxicology Society of Kenya. Currently a dean of the Dean School of Pharmacy, Mount Kenya University, and a member of the PSK National Executive Committee. He also served as a former lecturer at Technical University of Mombasa. Our other speaker for today is Dr. Jill Navalayo Mutua. She is a member of the Pharmaceutical Society. She holds a master's in clinical pharmacy from the year 2002, Charles University Prague in the European Union. She has been working at Nakuru Provincial Hospital, or formerly known as Nakuru Provincial Hospital, which is currently the Nakuru County Referral Hospital, since the year 2008. Without further much ado, ladies and gentlemen, let me welcome back Dr. Mike Mungoma. Let me welcome back Dr. Michael Mungoma to take us through today's webinar. Asanteni sana for listening to me. Dr. Michael Mungoma, are you with us?
Thank you, Mbao. Good evening, everyone. It's good to have you all here again this evening. This is the third of a series of webinars we've been having, courtesy of Maristops. And we are really grateful that Maristops supported us. Before I continue, there's a disclaimer. The presentation may not include all the relevant facts or the most up-to-date research, and the presenter is not liable in the event that omissions or errors occur. So today's topic again is ongoing contraceptive care and counseling. As healthcare professionals, as I'd mentioned previously, and my colleague Dr. Jill had also mentioned, this is an area that we need to put some focus on. During the first presentation, I also highlighted certain aspects, including results of a study that was carried out in Kenya previously, highlighting some of the perspectives of healthcare workers when it comes to sexual and reproductive health, especially among young people and adolescents. So some of the key facts, which is just a reminder, include that hormonal contraceptive methods include oral contraceptives, pills, injectables, and implants. They all prevent pregnancy mainly by stopping a woman's ovaries from releasing eggs. Of course, there are other mechanisms, including increasing the mucus secretion, not allowing the sperm to travel. Hormonal methods contain either one or two female sex hormones that are similar to hormones that are naturally produced by a woman's body. The other key fact is that oral contraceptive pills should be taken one pill every day. So they are most effective when no pills are missed. So that's important. So the pill is taken at the same time every day, and each new pack of pills is started without a delay. So we're talking about effectiveness. The other key fact is that injectable contraceptives are given by injection into a woman's arm or buttocks once every 1, 2, or 3 months, depending on the type of injectable. So injectables are most effective when women remember to come back for injection on time. So again, the issue of counseling and talking to the clients is very important. Next. So the other key fact, contraceptive implants are inserted under the skin of a woman's upper arm and provide continuous, highly effective pregnancy protection for 3 to 5 years, depending on the type of implant. When this time is over, new implants can be inserted during the same visit that the old set is removed. Many women seeking family planning services already know which method they want, and counselors should provide this method along with accurate and complete information. So it's important, accurate and complete information, either themselves or through a referral. So it's important here again that if you do not have the complete information about a particular method, it is not wrong or it's not bad to refer. It's so important for especially pharmacists, pharmaceutical technologists, or other health workers here in this webinar to appreciate that you're part of a healthcare system, that you're part of a wider network of professionals. So when we need to consult further or we need to refer, we should not hesitate. That is part of building confidence among our clients and ensuring that safety comes first before business. So it is the provider's job to ensure that a client makes an informed, voluntary choice and it is not denied, and that is not denied a method. Breastfeeding provides contraceptive protection for the first 6 months after delivery if certain conditions are met. So again, there are a lot of myths out there, and sometimes there's a lot of misconception of women who are going to be misdirected out there, that they're just told, once you've given birth, then naturally you should not be able to become pregnant. And there are a lot of cases of women out there who come back again to clinics or come back seeking clarification after they become pregnant, several months into lactation. So this method is called lactational amenorrhea method, or LAM. The natural effect of feeding only breast milk to a baby delays the return of fertility up to 6 months. But for this method to be effective, certain conditions must apply, these three, so that a woman must feed her baby only breast milk. 2, the baby is younger than 6 months. 3, the mother's monthly bleeding or periods does not resume. Next. So healthcare providers and contraceptive advice for adolescents. I've decided to um, bring a focus on adolescents or young adults because, again, this is an area that's becoming increasingly important uh, with the times that we're living in. Healthcare providers are ideally placed to guide adolescents in their decision about contraception. So it is important that they tailor their counseling approach. So it is tailored to adolescents. They maintain skills in counseling of all methods. Thirdly, that they address common myths and misperceptions. Yeah. So there are common myths, misperceptions that may inappropriately limit their recommendations or adolescent choice. So again, uh, even healthcare providers sometimes have their own misperceptions or their own myths, especially if they don't want to increase their knowledge base around contraceptives. So they have all these preconceived ideas about contraceptives, even though they keep these products in their stores, their pharmacies, in their clinics, in their hospitals, wherever they work. They may participate also in community activities, and some of them include distribution of contraceptives, but they have their own things again in their head. So they need, as healthcare workers, we need to address these common myths and misperceptions. Next. So knowledge dissemination. Sharing knowledge should aim to one, explore feelings and expectations around contraceptions. That as you are interacting with your clients, try and understand what their feelings are, what their expectations are. Some of them will say, might ask, do I need to start now? What is going to happen? And so on. Am I expected to continue using this once I start? Do I need to eat special foods and so on? Two, help an adolescent to choose a method of contraception that best fits his or her needs and personal beliefs. So it's important that we engage these clients, we engage them. What best fits his or her needs? And here there's an emphasis of his as well, because there's no hard and fast rule saying that contraceptives are only for girls. No, boys are also getting engaging in early sexual activity, and they need to be aware and they need to be informed of the methods that are out there and how to use them, including barrier methods, so that they don't go around uh, just carrying out experiments and trying things without proper knowledge or proper guidance. So there are several ways. One, just to highlight again, because counseling is quite a large area when it comes to contraceptive care. So there's the gather approach. And gather, so the GATHER stand for greet, ask, tell, help, explain, and reassure. And this is an approach that can be adopted wherever you are working or practicing, that you're able to greet, your client, ask, tell, help, explain certain things, and reassure. We'll just get to a few details. Next. So there are certain essentials for the contraceptive counseling of adolescents. One, are you welcoming? Part of being welcoming is not looking judgmental. You should not look too serious. You should not look scary. What to ask? What exactly do you need to ask this client? Have you checked? What to tell? Have you reassured her? So those are just some of the essentials of contraceptive counseling for adolescents. And the last point there again is reassuring, just to ensure that this client is comfortable while leaving your premise. Next. So there are some relevant considerations, just from the previous slide again, what to ask. Some of the things to check is her reproductive and sexual history, including previous and current use of contraception. You need to ask, are they using any methods? Are they sexually active, or are they planning to be sexually active? Her medical history, including any specific conditions and medications. So do they have even things like stomach issues? Do they have any chronic conditions? Are they on long-term medications? We saw previously that the use of certain antibiotics like penicillins, tetracyclines, and also certain anti-TB drugs can reduce the effectiveness of certain contraceptives. So these have to be taken into consideration. Her current relationship and whether she has any concerns. So this requires again that the client is comfortable discussing. Current relationship, is there coercion in that relationship? Is she concerned about this relationship? The concerns could be: is she there for short term? Is it long term? Does she have any expectations out of the relationship? Is she there to eventually get married or start getting children or not? Her needs and expectations from a contraceptive method. Yeah, so some of the needs would be that she might prefer contraceptive method where she doesn't have to remember taking or remember using. Um, she probably wants a contraceptive that doesn't have any side effects or only some side effects that she's probably been told about. Her ability and motivation to use contraception regularly and correctly, that also has to be considered. Her ability and motivation. Part of the ability would mean if it is something that requires daily use or daily taking, like a pill, is she actually able to do that? Um, are her circumstances enabling? Because it could be as simple as, if she's going to take a pill, then does she require to is she expected to do this discreetly? Does she have the ability to put them somewhere where she's able to remember? Her thoughts on using an injectable and long-acting reversible method, that has to be discussed again, because it's one of the options. The level of support she has at home from the community and or her partner. Yeah. Is she having any support? Does she require any support from home? Because that could be the other question. Does she require the engagement of somebody else? Does she have a sister? Does she have somebody else she stays with? Is it something that requires engagement of other parties, including even maybe the parent? Whether she needs to hide her use of contraception. So again, that is tagged to the ability to use this method regularly and correctly. Next. So other relevant talking points again is to check his or her awareness of methods and whether he or she is ready for a preference. Yeah, so you have to check on readiness. Are they ready? Are they aware of these methods? The accuracy of the knowledge, including his or her fears and concerns. Yeah. How accurate is the knowledge about what they want? Because some of them might come and just say, I want this, but what do they know about it? Methods matching needs and expectations have been discussed. The identified potential options are acceptable, again, to him or her. Yeah, because you might find certain adolescent boys coming and saying, and remember again, adolescent here by definition from the national guidelines is 10 to 19 years. And if we put that into perspective, we even have people who are 17 years going to college. And when they get to 18, again, we sort of refer to them as adults. So it becomes very, very important to take note of that. The identified potential options are acceptable to him or her. If cost is an issue, how is he or she going to pay for the contraception? Whether STI screening is appropriate. So STI screening again comes in. Does she need to be screened? If you think he or she is ready to make a decision, help him or her make an informed choice that matches contraceptive needs and expectations, as well as the lifestyle. Next. So the other thing again is still on some of the relevant talking points, what to tell, how the method works, how effective it is.
Dr. Mike.
Yes, Dr. Jill? Hello, Dr. Jill, did you call me there?
You're there.
I didn't hear you. Dr. Jill, did you say something?
Is it only me who can't follow? It's breaking. It's only on my side.
Mbao, can you hear me and follow me?
I can hear you and follow you. Dr. Kindly proceed.
Okay, thank you.
I will alert you.
Okay.
Okay. Anyway, thank you for notifying me. I'll just make sure that I'm audible. So the other relevant talking points. So what to tell, how, so what to tell, yeah, to tell the client is how the method works, how effective it is, how to take it correctly and consistently, and also when to start. Yeah, when to start. How it will affect her menstrual cycle, what the potential side effects are and what to do if they occur, what the non-contraceptive benefits are, if that is relevant, and then when to return for a follow-up appointment. So it's important to discuss all this, yeah, especially side effects, because this is common and it varies from individual to individual, as we discussed in the previous webinars. And sometimes it's very difficult to explain because not everybody is going to suffer the same side effects, or not everyone is going to have side effects at the same time. Some of them can be delayed, some of them can be immediate, and so on. Next. So, have you reassured the client? For the majority of healthy young women, the benefits of modern contraceptive methods outweigh the risks. So, this is important to take note. And some of them even have certain benefits, including prevention of certain types of cancer, like cervical cancer. The correct and continuous use is essential for best results, and she should not stop her contraceptive method without first contacting a healthcare provider unless it is an emergency. That she has taken the first step to an empowered, healthy, and safer sexual life. So it's important that she is informed. You've taken a step to be empowered, live a healthy and safer sexual life, because unwanted pregnancies can sometimes can be very traumatic. And checked whether she has any remaining fears or concerns about her contraception. That one is also very important. That at the very end, are there any remaining fears or concerns about the contraception, so that they don't go away with certain unexplained or unaddressed fears, and then out there they make other decisions whether to stop or to break when they are using the contraceptives, if they are using oral contraceptives and so on. A particular case in point is we had our own experience last, I think it was last year when we were being trained on this one. And there was a particular community where it was raised as a case, sort of a case study, where These women used to go for clinics, mother and child health clinics, and there was also reproductive health services included in those visits. And when implants were proposed, and some of the clients actually agreed to get the implants, when they went back home, some of their husbands or their partners were, they were not happy because they said it seems like their partners or their wives were playing tricks on them and they were going there for other things. So we even had extreme cases where some of those implants were being ripped off the body. And of course, this now becomes a fear or a concern about contraception, especially if uh, the client did not get full information about implants, and they also didn't realize that once it is inserted that it can actually be sometimes can be felt, or exactly where this thing is. And if there are partners or husbands who are aware of this, then they need to get involved in this process. Next. So counseling, this is a very important and necessary sort of skill that everybody in every healthcare worker needs. Acknowledging her need for confidentiality and privacy. So, for example, being able to ask an accompanying person to wait outside. So that becomes very important, especially when you're handling maybe an adolescent who has come seeking for information. They don't have to really be coming to look for commodities, but they're coming for information. Acknowledging her need for confidentiality and privacy, recognizing the need for a different approach and language for adolescents versus older women. Yeah, you may need a very different sort of approach and language. Creating an open and empathetic environment. So remember again, just to be able to allow these clients to talk freely and be able to take in information, because if they feel free in an open environment, they also are able to understand what you're saying and pay a bit of attention. Empathetic environment being again understanding and not sympathetic. Next. So there are certain motivational interviewing techniques which are part of the counseling procedures. One, express empathy, seek to understand feelings and perspectives without judging. So you're non-judgmental, but at the same time, we're saying that you understand the situation, you understand how things are. Develop discrepancy, create and amplify the discrepancy between current behavior and broader goals and values. Yeah. So if there's a current behavior that is being expressed, if maybe uh, this person is engaging in sexual activity and they have certain reasons why they're doing that, they're saying maybe it's part of their lifestyle, it's part of sometimes they don't have much of a choice and so on. As you are counseling on contraception, think of the broader goals as well as values. Yeah. If it is prevention of STI, put that as a value. Yes, this thing is useful because then you're not able to contract an STI, or a broader goal. These methods are available for you to make a choice so that you do not get unwanted pregnancies. Roll with resistance. So new perspectives are invited but not imposed. And resistance is reframed to create a new momentum towards change. Yeah, so new perspectives are invited but not imposed. Then fourth, some of the techniques, the fourth one is support self-efficacy. Use belief in the possibility of change as a motivator. Yeah. Next. So some of the usefulness of motivational interviewing. One, explore and manage ambivalence towards pregnancy and contraception. So it's important to explore these ideas and find out what are their perceptions towards pregnancy and contraception. Two, identify inconsistencies between life goals and sexual behavior. So it's important as you're counseling, you're also finding out what are the life goals, what's the plan? Yeah, what's the plan? And engaging. Yeah. The difference between advising and counseling. Counseling, there's more of just listening and sort of allowing the client to also listen to themselves, lay down what exactly they are thinking and saying, and that by doing that, then some of them can actually make informed decisions, because if nobody is listening, sometimes you don't see what you're thinking. The other thing is to anticipate potential compliance and adherence issues. So to anticipate, yeah, once as you're counseling, you can tell whether there's going to be compliance here or not. If it is the barrier method, for example, and they're already expressing, do I have to use it all the time? How do I carry this thing? How do I carry a condom all the time? Or for example, if it is a girl, they might say, why should I be carrying it? So that already tells you that there might not be compliance or adherence to that particular method. The other point is to assist in the selection of the most appropriate method. And of course, now with this one, as part of the wider training when it comes to contraceptives or family planning methods, there are several tools that are out there, including the MEC, so minimum eligibility criteria, MEC wheel, which is a tool that can be used to determine the most appropriate method. It has quite a lot of details, including if there are any pre-existing conditions, if somebody's taking other medications and so on, and it actually guides you to the most appropriate method. Next. So certain aspects to check with female clients, again, how awareness of methods, whether she already has a preference, because they might come in with a preference, whether they've heard from friends or whether they have read about it or they know something about it. The accuracy of her knowledge, including her fears and concerns, methods matching her needs and expectations have been discussed. They identify potential options are acceptable to her. If cost is an issue, how is she going to pay for this contraception? If it is going to be ongoing, whether STI screening is appropriate. So again, if you think she's ready to make a decision, help her to make an informed choice. Next. So as a summary, again, based on just a few things we've mentioned there, creating a positive experience when clients are consulting about contraception is important. So one, to provide accurate sexual and reproductive health information. Two, address and correct misperceptions. And thirdly, choose a method of contraception that best fits your patient's needs and personal beliefs. Let's move on. I think I have a few more key facts that just to share again at the end. And here again, it's just part of just increasing our knowledge, again, reminding ourselves of these key facts. Fertility awareness methods require a couple to know the fertile days of the woman's menstrual cycles, so the days when pregnancy is most likely to occur. During these fertile days, the couple must avoid sex or use a barrier method to prevent pregnancy. So again, there has to be collective participation. Yeah, so there has to be some level of collective participation here. Next key fact, that barrier methods are either devices, male or female condoms, examples, that physically block sperm from reaching an egg, or chemical spermicides that kill or damage the sperm in the vagina. So the effectiveness of these barrier methods greatly depends on people's ability to use them correctly and importantly every time. Yeah, so they use it correctly and they use it correctly every time. Sorry. Next. So IUDs, intrauterine contraceptive devices. So these are small, flexible plastic devices inserted into the woman's uterus. So the most common IUDs contain copper, and they work by preventing sperm from reaching an egg. So depending on the type, IUDs can provide protection for 5 to 12 years. Next. So the other key fact, EC pills, emergency contraceptive pills, can help prevent pregnancy if taken within 5 days after unprotected sex. So the sooner they are taken, the more effective. They lose effectiveness with time. So they are not meant to be used for ongoing contraception, as was mentioned previously by Dr. Jill, in place of a regular method. Next. Those are some of the references. Remember again, I want to reiterate the fact that these series of webinars have been sort of just to sensitize people, yeah. And it's important for us to continue training ourselves in family planning methods so that we get more and more information and we get more and more confident in one, sharing the information and actually engaging our clients. Dr. Jill, maybe you can add something. Dr. Jill?
Hey, good evening. So I'll just, I have some points to add. You're getting me, yeah?
Yes.
Now, the first point I wanted to reiterate.
Yes, we can hear you.
And through adolescents, like we said, in Kenya, in Africa, in many groups, be it Facebook or just even people around you, you'll find that there's a lot of discomfort when you're talking about contraceptives and adolescents. Now, we just need to stress that when it comes to reproductive health, the laws which are there presently, they're dynamic, okay? But people need to know that the law identifies people we called mature, I don't know if they were called mature children or what were they, mature adolescents. These are people, because you find people arguing that when you give contraceptives to children or to adolescents, let me say adolescents, you are telling them it's okay, you can have sex, we are fine. No, it's not that. We always, the default is abstain, isn't it? That's the default, abstain. But when you have a mature adolescent walking into your pharmacy or into the hospital, coming to you with confidence that, well, my life is like this and I need contraception. You need to harness that moment, not only for family planning, but also for HIV and STI. Yeah. So when they come in, yes, they say that, okay, first of all, I'm not raped. It's not a rape. Of course, if it's a rape, you have to take another dimension. Yeah. But what I talked about last time is what I was calling Romeos and Juliets. In America, they call them Romeos and Juliets. Romeos and Juliets are people who are under 18, and for some reason, they have decided they're having sex. So you start with abstaining. We need to abstain not only for cause of pregnancy, but because of STI and HIV. But if we have moved from abstaining and we are engaging and we don't want a pregnancy, we don't want to say, now you have to come in. And the law protects you. The law protects you, so you don't feel like you're breaking the law by giving a mature adolescent a contraceptive. So next time we can share this. I can get back to the reproductive health people in MOH to exactly cite what part of the law that is, but I can tell you with confidence, this always comes up and it was resolved. We have mature adolescents, girls or boys who walk in and they're having sex. The second thing is about boys. I always wish we can drop in boys. If you have a boy coming in for condom, take time to talk to that boy about STI and HIV and contraceptives for the girl that he's sexing with. The other issue is the MEC wheel, what Dr. Mike has mentioned. It is a very, very, very important tool. When we will be training pharmacists and pharmacists on reproductive health, it was supposed to have happened this year, by the way. There's that tool is called the MEC wheel. It is a wheel which makes your work very easy because it shows you who can take what and who cannot and why. In fact, we have from 1 to 1, 2, 3, 4. What is, for example, if you use the MEC wheel, I come in, I'm 40, I want contraceptives, but I have history of heart disease. Can I do this? So it helps you a lot. So always get your hands on this. The reproductive health MOH have this. When they train us, they'll give us that. Then my last point is emerging issues. Emerging issue. There's something people call the herbal contraceptive. When your patients or clients will come to you, this might come up, and it will come up that there's something they call the herbal contraceptive. How good is it? So we have talked about this on social media for many months, many years. It's called Sophia. It's one tablet. It is taken monthly. It's from China. And many of our ladies are using this, and they will ask you about it. So you need to know this. The PPB requested the National Quality and Control Lab in 2016 to test these pills, which were banned in 2009 by MOH. They have been banned by MOH, but they're still in the market. But they're not in pharmacies, they're not in chemists, they come in briefcases. So when the NQCL tested the Sophia pill, they realized that they were so inconsistent they were very, how can I say, the composition was very inconsistent, but you could find that some had nothing, no content, but there is one which I have never forgotten. It contained 3 milligrams of estradiol. 3 milligrams of estradiol is 3,000 micrograms. Now remember, the Femiplan has 30 or 35. So this Sophia pill had 100 times more, 100 times level of the Femiplan. And some had, I don't know, 50 times. So what you tell our women is that there's no herbal. It is, it's like if you take 100 Femiplan pills and roll them into one, of course, it might protect you against pregnancy. But can you imagine that estrogen bomb for the uterus, for the heart? And when they fail, the babies who are born to women who have an overload of estrogen have a lot of issues. I remember Dr. Francis Kimani, the former director of health, when he banned it, he said, some of those babies were born and they had breasts, they had uteruses at birth, some were menstruating at age 2, 3, 4. So Sophia is not a herb, it is a Chinese pill which was made. In fact, I had in China, it's used for dogs, for bitches, yeah? So this information you need to have and dissuade everybody from taking that pill. Mike, over to you.
Thank you, Dr. Jill.
Over.
Mbao,
Yeah.
are you still there?
Yes, I am still here, Daktari. Asante sana for your wonderful presentation, and thank you very much, Dr. Jill, for clarifying to us that Sophia is not a herbal and it's already illegal, because I'm finding majority of our members, and if you go to Instagram, their pages, you'll find on social media that they are marketing Sophia as a herbal pill. So Dr. Jill and Dr. Mike, we're going to handle the questions right now. And the first question is from Dr. Ben Ogonji. Most women complain of bleeding when using implants. How can this be controlled? Dr. Michael Mungoma, over to you for that.
Yes. So I just want to make a statement here that bleeding is one of bleeding or spotting is one of the side effects that is expected, both for oral contraceptive pills as well as injectables. So what normally happens is that if bleeding persists beyond 3 months, this can be treated with supplemental estrogen. This can also be combined with or taken just as estrogen, but it can be combined with a non-steroidal anti-inflammatory drug. And this combination of the use of either of the drug seems to be able to control bleeding that is associated with taking oral contraceptive pills, especially progestin-only pills, yeah, or medroxyprogesterone acetate injections. So that is just one way of controlling that. There are also, I've seen another question there, maybe I'm just preempting, but maybe Dr. Jill can say something.
About the management of the side effects,
Yeah.
Yes,
Now,
Daktari.
so we always know that for people to be compliant and comfortable, the side effect should not overpower the initial indication. So we reassure there's nothing wrong with you, because that is usually a fear. There's nothing wrong with you. It's just your body is reacting to this. Because like I said, our bodies have their own levels of hormones. So these are more hormones. Some react well, some don't. In fact, when you're doing an implant, I remember the ladies are told, if within 1 month you lose, I think, up to 5 kilos, come back and we will remove it. It's not for you. So you reassure there's nothing wrong with you. But if, and Dr. Mike has mentioned how to manage, but if the management is out of reach or the discomfort is too much, I mean, I can't imagine somebody bleeding for 1 month. It might ease with time. But if in 3 months you are still there, just come back and we can give you another method. That is the advice. You don't have to stay with it if you're suffering. But if after 3 months your bleeding is still there and you are not able to manage, as Dr. Mike has informed, there are other methods. You come back and we can give you another method. That is information they give at Reproductive Health.
Okay, now to follow up on that question, we can see that the second question, or it's an anonymous attendee, and also the second question: how do you address menses that last up to 1 month for a lady on the Nord plant? Do they remove the implant, or what is the solution? Dr. Jill, again, what answer would you respond, and how will you go about it?
Like I said, in the first month, you will have all those. Month 2, things should get better. Month 3, we should be able to know if we are handling or not. If in month 3 we are still having that kind of bleeding, now we enter a risk of anemia, of course. We enter a risk of instability for the woman, her mental status, and also her family. I mean, she's bleeding for 3 months, it doesn't work well. So there's nothing wrong with you, but the contraceptive might not be good for you. If up to month 3 we are having that, like I said, if you lose up to 5 kilos within the first month, you're advised, no, this one is not for you. So if up to month 3 we are having that kind of bleeding, we usually advise them to come back. The implant should be removed, and they can get another method. It's not a must.
Asante
Yes,
on that.
and just to add on again, I think the use of NSAIDs there is important. Even just something like naproxen, uh, 250 milligrams can be taken twice daily for 5 to 7 days, and just to see whether that can be controlled. Just as Dr. Gila said, again, if this persists, and one that it becomes now a disturbance, then other options have to be considered. If it was an implant, then we have to remove the implant and think about other contraceptive options. There are studies. I don't know whether they have concluded these studies, but it's interesting. There's an antibiotic, doxycycline, that is also showing some promise in controlling, especially specifically what has been asked there as no plant, progestin only contraceptive, progestin only contraceptive. So doxycycline seems to be something that is showing promise to about 20 milligrams twice a day. But again, there are no, I'm not sure whether this has been approved, but it seems to be working to control that kind of bleeding. Yes?
Asante Daktari for your response. Another anonymous attendee is asking, which are the natural methods of contraception? Dr.
Okay,
Jill, probably you've,
yeah.
Dr. Mongoma has handled lactation amenorrhea, and last week Dr. Mongoma handled others. So kindly take us through, probably to bring to tabs the attendee.
Okay, Dr. Mike, correction, doxycycline, I think you mean 200 milligrams, not 20.
Oh, yeah. Yes.
Yeah. Now,
Sorry.
back to natural methods. Whenever we're talking about natural methods, it's a disclaimer, it's just a small joke that the presenters from reproductive health always say, it's the fastest way to get pregnant, yeah? But anyway, it doesn't mean, you don't tell that to the patient, of course, but amongst us, because here it is working with nature. Now, we have LAM, which is lactational amenorrhea method, but this one I told you, last time I said it has 3 conditions, baby up to 6 months, no menses, not even a drop. If that woman has seen a drop of blood after delivering within the 6 months, it's not good. And lastly is exclusive breastfeeding. You have to explain to women what exclusive breastfeeding means. No water, you don't give baby water and sugar and glucose, and then you say you're exclusively breastfeeding. The other is FAM, fertility awareness method. These ones are, you find that when we talk about family planning, we're not only always preventing pregnancy. No, family planning is also to assist people. Hello, you can hear me?
Yes, we can
Yes,
hear
we
you.
can hear you.
Yeah. We're not only preventing pregnancies. When we plan families, we are also assisting people who are having, who want children and they're not having them. So you'll find that fertility aware methods might work very well for couples who are trying to have a child, not for those who are trying not to have a child. It works for both though. Now, fertility awareness method is just a woman needs to know her cycle. There's a wheel which is also available. It shows which days she's safe. Usually, and when we're talking about safe, please, your take home should be, whenever we are talking about menstrual cycle, day 1 is the first day of menses. When I was training in Lodwa in Kisi, it was always a very interesting question and answer. Most people, especially men, had no idea what is the first day of menses. First day of menses is the first day when there's blood, not the first day after, because that one ruins everything, yeah? So first day of menses up to day 10 for a woman who has a 28-day cycle. Usually up to day 10, they are safe. Then from day 11 to 19, they are not safe. And then from day 20 to menses, again, they are safe. So when the woman is aware, there are many ways of knowing if she's safe. There's what they call, you have a temperature check. You can have what you call, how do you say, cervical mucus. Women can watch when they have, when the mucus changes. But it's just about being aware. And when they are not safe, they abstain from sex, or they can use a barrier method. Those are the family. And then there's also a bead. When we are distributing family planning methods, there's what we call, there's a bead. It's what do you call that thing? It's a necklace with beads with different colors. So a woman can use that to count. And this one is very popular in northeastern Kenya, or in those communities where we have Islam. You find that this one is very popular there. It has beads, I think 32 beads, and they are different colored. So the woman can trace when the beads change color, you find that she knows when she's fertile and when she's not fertile. And when we are there, I can take the last question.
Dr. Jean,
Okay.
Dr.
Over
Jill,
to you.
just before you take it, I'll probably
Yeah.
to enlighten members, the actual name for the temperature for the natural method, there is the basal body temperature. In basal body temperature, just before ovulation, a woman's body temperature falls by 0.5 degrees Fahrenheit, and it rises a full degree. This is due to the influence of progesterone. This is at the time of ovulation. So there's a distinct difference in the rise in temperature. 1 full degree during ovulation, and to combine with the cervical mucus or ovulation, the fluid for the fluid dietary is the fluid changes through the fluid color changes and also the texture changes the throughout the cycle. It changes from scant, sticky to cloudy and thick, to sleek and stringy. And each of these types of mucus is related to hormonal shifts that naturally occur. And just right before ovulation, the mucus from the cervix changes from being cloudy to scanty to clear and slippery. The consistency of ovulation mucus is like that of the egg white, and it can be stretched between fingers. It is at the peak. This shows the peak of fertility. So when a woman is able to, she stretches her fingers, the cervical mucus, and it's the egg white. That shows the peak of her fertility. And after ovulation, the mucus tends to dry up. These are also her safe days, and the failure rate there is at 3%. So, Daktari, to combine both, a patient can also combine both the basal body temperature and the cervical mucus stroke ovulation. It's known as symptothermal method. This combines both methods and combines the cervical mucus and the basal body temperature, where one observes the temperature whilst observing the cervical mucus. You watch for mid-cycle abdominal pain. Couple must abstain from sex until 3 days after rising temperature, or the 4th day after peak of mucus temperature. Over to you, Dr. Jill. Kindly give us the next question, which says, which contraception method should be considered for adolescents living with HIV and AIDS?
Yeah. So, just to clarify, to add something on the natural methods, like I said, you'll find that people who follow basal body temperature and those days, usually you'll find it's like I said, it's the other side. It's people who are trying very hard to have a child, not only those who are preventing. But so it works for both. Yeah. Now, when it comes to HIV and AIDS, you find that adolescents who are in this situation, sometimes they are born with it. So, of course, depending on their compliance with their HIV medication, you will find that there are some who are not on any medication since they were born. So, the barrier method works perfectly for these people. Yeah, barrier method works because you'll find adolescents born with HIV and some are not on medication or inconsistent. Some are not sick, some are, yeah. So barrier method, condoms work best for them. When it comes to hormonal drugs, I think there's one, Caletra. Caletra is ritonavir stroke something, lopinavir. That is the one drug which reduces the effectiveness of estradiol. So when you have clients who are on Caletra, luckily Caletra, I think nowadays is it's not a first line, but you still have patients on Caletra. So if you have a patient, a person who is HIV positive on Caletra, they cannot take hormonal contraceptive that contains estradiol because it decreases the effectiveness. But Mike, I think you can add something to that. I think it might be
Yeah,
something.
you're right, Dr. Jill, mentioning that certain medicines for HIV, also certain medicines for the treatment or management of epilepsy and TB, like I mentioned the other time, rifampicin, also reduce the effectiveness of these contraceptives, meaning additional methods or additional protection needs is required during the time when they are taking these medicines. Other complementary drugs, again, herbal medicines like St. John's wort, also reduce the effectiveness. So engaging the client to make sure that they're not taking other things at the same time, or if they are, for good reason or for whatever reason, that they are advised correctly. Now, another thing, just to mention, because something has been asked there about the pain that is associated with implants. This is sometimes expected. It's one of the side effects when these insertions are put. These implants are inserted. Clients need to be told to expect. Sometimes the description by clients is that the hand feels heavy. So that is a very typical way of expressing the pain. The hand feels heavy. They should just manage that with over-the-counter pain relievers, yeah? Ibuprofen, paracetamol should be able to take care of that if they take it for 1 or 2 days. And they need to be informed that, because the more stressed they are, then the more unaccepting they are of the method or how they feel moving forward. Um, I think there was something else here about a client who removed the implant, expired and not yet gotten a menstrual period. We mentioned in the previous webinar that clients should be able to get back into their normal menstrual cycle within 3 months, but sometimes it can take even up to 2 years. So it varies from person to person. There is no definite time when people get back to normal. This should be part of the counseling process so that they're aware and they're also reassured that yes, you will get back to normal, but it might take a while or it might not. So that psychologically they're also prepared as they're moving into this, taking up these methods, and they get into this in an empowered state. So somebody else, Dalmas, is saying for a woman who is exclusively breastfeeding and has not yet resumed her menses, let's say now for 3 months, is safe for her to have unprotected. So I've already mentioned there that this is again tagged to the LAM, yeah, method, where exclusive breastfeeding is important, and two, that the lady did not get to a menstrual cycle soon after giving birth. Those, if they're able to fulfill those three conditions, then they should be able to remain safe, not to get pregnant. So the three conditions again: that a woman must feed her baby only breast milk, that the baby is younger than 6 months, and that the mother's monthly bleeding does not resume. So that is part again of the counseling that needs to be given to lactating mothers so that they do not get into situations where they were not breastfeeding because of work, because of other things, or they had to travel, and then in the whole process, they got pregnant. Bao?
Yes, Dr. Mongoma, there's a question. Have you answered it? Is there danger of being confused to be COVID-19 infected due to ovulation when temperature is taken? And a point to note that I've said is it's only 1 degree. It varies during ovulation. The temperature varies by only 1 degree. Is there, Dr. Do you have a disclaimer for that? Dr. Mongoma?
Bao, I didn't hear you.
There's a question that was asked on the COVID-19 infection and ovulation, the variance in temperature, because you guided us through the COVID-19 dialogues. How do you guide that person in matters the temperature check and ovulation?
So if my question, I think what I'm understanding is now the relationship between COVID-19 temperatures and
ovulation temperatures.
So are you saying that this is a client who has been using the natural method of checking the temperature, and they also have COVID-19? Is that what I'm hearing, or is it during the pandemic? Yes, Dr. Jill?
No, I think like Mbao gave us the difference. The temperature change is 1 degree, isn't it, Mbao?
It's only 1 degree.
Yeah. So what the person is asking during ovulation, since there will be 1 degree higher, can that be confused for COVID? I think that is what the person is asking. And 1 degree, when we are not sick, we range between 35 and 36. And if if you have paid attention to your temperature checks during entry to supermarkets, you might be told that you are 34. Yeah, that happened to me a lot of time, and I was like 34, and I'm walking. Anyway, what I'm saying, for that change, unless you're sick, you will not be past 37 degrees unless you have issues, unless you have an illness in you. Yeah, if I got the question right,
Yeah.
that 1 degree change will not take you past 37 degrees. It should
Ah,
not.
Yeah,
asante,
maybe just to add on to that,
Yeah.
the guidelines also say very clearly that particular method requires, requires quite a bit of attention by the lady. Yeah, that before they start using that as a method, that they check their temperatures for at least maybe 1 or 2 cycles, and that they're actually able to do it so well so that they can notice the difference in the change of temperature. The first time it might not come out so correctly, so it might not be the first method. They would have to use barrier methods or other methods until she can actually determine correctly the change in temperature. Remember, again, there's the use of thermometers or other devices. Currently the thermogun is something that is in fashion, but again, the use of thermogun again is something that again is debatable, because there are people who are placing the thermogun on the forehead, there are guys putting it on the hand, some of them are putting it very close to the body, some of them are putting it 2 centimeters away. So they have to, first of all, be very proficient at taking their temperature first for them to take up this procedure or take up this method.
asante sana
So
Dr.
there's
Mwalimu.
something, yeah, I just saw something there by Dr. Mogoi on the side. Contraception is still a foreign concept in far-flung areas in and Africa at large. So we still have communities that are contraceptive averse. How do we bridge this knowledge gap? I think it's important for us as healthcare workers to close these gaps, yeah, and I first even identify these gaps and see how best, because in the previous presentations, and Dr. Jill also added something there, that culture and tradition play a very important aspect when it comes to access to reproductive and reproductive health services. So there could be places where it's taboo to talk about this. There could be places that geographically or physically it's a challenge to access these people, or these people to access these services. So it is for us as healthcare workers to identify ways of moving closer to them, even if it is not providing the commodities, but it's providing the information and empowering people out there, yeah, through information sharing and through demystifying some of these things that are related to contraceptives. Some of them we haven't fully discussed, but there are even communities that look at contraceptives and there are myths around contraceptives saying that when women take this, then something happens to them. There's all manners of stories. Some of them say that they become sexually inactive, or they become cold, and a lot of all these things contribute towards poor uptake and poor outcomes when it comes to sexual and reproductive health. Bao?
Asante sana daktari, and I'll go through probably when Dr. Jiga, Dr. Mungoma, and Dr. Jill are going through the probably before you give us your final remarks. I'll go through the chat box. Dr. Sally Motieno, that is Dr. Sally Motieno from Turkana County, says that a good job, Dr. Mungoma. Dr. Ben Ogoji says very elaborative and informative. You've gone through Dr. Ruben Mugoi's comments, and Dr. Hanan Banafa says, thank you so much for the informative session. This is Dr. Simon Onyango left us a comment and said, this is to remind us that under human and sexual rights, it is the right of a woman to choose when and with whom to be pregnant. So as we guide them, it is important to keep this it is important to also keep this in mind. Dr. Mungoma and Dr. Jill, I will ask for your parting shot kindly. Dr. Jill, we go first.
There was a concern. Somebody was asking about. I'm wrapping up, but also just addressing that concern about if there is a non-hormonal
Yes,
apart from implant, and the non-hormonal
yes.
method, long-term method, which is non-hormonal, is IUCD. IUCD is one of the most effective methods. Why? Because, like I said last time, it costs 70 cents, 70 American cents. It covers a woman up to 7 years or 10 years. It is, when inserted correctly, it has no hormones. So for those women who battle with this bleeding and these feelings and headaches and what, it is actually the best method. IUCD is a very good method for women who are in stable relationships because they says that there are complaints when a woman has multiple partners that they react to the coil. I don't know how scientific that is, but one thing about IUCD, it is good for women who are stable in marriage or with one partner, but it's one of the most cost-effective methods, long-term methods, because it has no hormones. For short-term methods, which are non-hormonal, of course, those are the barrier methods, and then the short-term methods. So my parting shot is, we are supposed to help people. We have 18% unmet need, 18% of the population of women who are engaging in sex, whether in marriage or with their adolescents. They are not planning a baby, but they are not using anything. So we have the oops pregnancies, especially at age 19. When I am at the hospital, you find that many discharges are 19-year-olds with babies. Well, it's good, but they're going back to their parents with babies. So these are the people we should be talking to, and we should be champions, not to tell people not to have children. No, family planning is about helping people to decide, like Mike said, when, how often, and with whom to have children. That is our role. Back to you.
Asante, Asante, Daktari. Now there's a member who's texted me on WhatsApp, so I'll request Dr. Mungoma to respond to the question. A 23-year-old, this is a pharmacist from Muranga County who's asking this. A 23-year-old lady on depot injection from August 2020, and the face has pimples since then. She's so uncomfortable. That is quote unquote cosmetic concerns. So, Dr. Mungoma, as you're giving us your parting shot, kindly respond to that question.
Okay, so one, some of the side effects or adverse effects that are associated with these hormonal contraceptives can also include acne. Yeah, so again, this varies from person to person. This particular client, I think like I said previously, we may need more information, again, a bit of counseling just to find out how long they've been taking, what else they're taking, what else is going on in their life, including their lifestyle. Is food contributing, and sugar, and so on and so forth, for us to have a very specific maybe answer or remedy for those pimples or acne that are being seen there. But again, I think I want to commend the person from Muranga taking note of that. But what I would say is that gather more information about the client before thinking about giving them something else. Yeah. And then also just find out a little bit more about their reproductive, or I mean, the sexual reproductive health needs. Yeah. Do they need to change that? What could be the other options around that if depot seems to be contributing towards that concern about their skin? My parting shot is that as healthcare providers, can we increase our knowledge base? I think that's so important. Let's look out for training opportunities on family
True.
planning. Let's keep our minds open,
Yes.
and take some time to really look at the products that are in our practice, whether you're private practice or whether you're in a hospital, as well as trying to look at this, important aspect of MTM, medication therapy management, because a lot of clients who would probably be needing or using these products, yeah, or these contraceptives, might be on other medications and they do not feel obliged to report that. So as we are looking at these clients and looking at their prescriptions and probably noticing their frequency at your practice, then you may want to just find out a little bit more about the sexual and reproductive health needs. Thank you.
Asante sana, Dr. Michael Mungoma. And Dr. you can hear me well?
Yes.
Hello, Dr. Mungoma, you can hear me well?
Yes.
Okay, asante sana. Thank you very much for your presentation tonight. And I can see Dr. Gladys Mwangi, the Dean School of Pharmacy, Kenyatta University is here, and probably yourself as the Dean School of Pharmacy. MKU, you are able to be cognizant that we need to increase change the dynamics in which we are training the pharmacists who are being released outside from the country. And thank you very much for senior professions who have taken time to join us. I can see Dr. Sindani, I can see Professor Keegan is also here. So for that closing part, I will ask Dr. Spencer Ochieng. Dr. Spencer Ochieng, I've allowed you to talk. I want you to give a vote of thanks to our speakers for tonight. Dr. Spencer Ochieng, are you with us? Dr. Spencer Ochieng?
Yes, I'm here.
Yes, Dr. So I will request you as a senior member of the profession to give a vote of thanks probably to the sponsors of these webinars in absentia, and also to our esteemed presenters for tonight, Dr. before we close it.
Okay. Thank you very much. I just want to thank the speakers for a very interesting discussion. I think the whole issue, the whole area around contraceptives is one that's very pertinent with our very young adolescent population that's growing by the day, and the way our cultures are changing. I think contraceptives is a key area that we need to keep abreast of. So I want to thank our sponsors. I think these talks are very interesting. And we look forward to very many more. I think our presenters have covered the area very well. And of course to PSK for continuing to facilitate these meetings. I find them very interesting. It really is good when almost every day of the week there's something that we can log into and keep us going. So I know it takes time to prepare for these presentations and to go through them. So to our speakers, kudos, and also to our sponsors, thank you very much. Yeah.
Asante sana, Dr. Spencer Ochieng, and we also thank you for your resolute support to the profession and to the society, the professional society, the Pharmaceutical Society of Kenya. Dear members, we have come to an end of our great webinar, and we have sadly come to an end for the year on the closure of this webinar. As Dr. Spencer Ochieng has said, each and every day of this week, we shall be having webinars. Always ensure that you subscribe. For this event, kindly ensure that you subscribe. I also, a polite reminder is that we are only able to give the CPD points to PSK members. For the pharmaceutical technologists, you are able to get your points. But to the PSK members, ladies and gentlemen, kindly, let us be able to support our house and let it grow and grow strong. Apart from that, ladies and gentlemen, we will be briefing you each and every Sunday evening. You will be receiving an email with all webinars lined up. Next week, we are having 2, and our last webinar shall be on 16th of December. It is a webinar on distribution, streamlining distribution and supply chain of healthcare product technologies. That is just a gist I've thrown into the air for you to be able to understand when our last webinar is. So members, kindly ensure that you're up to date on your CPD points. I wish you a good night and ensure that you keep safe. Nawatakia bila lingine la kusema, nawatakia kila laheri na nawaombea usiku mwema. Asanteni sana kwa kuungana nasi na kwa kuja kwa mkutano wetu wa leo. Usiku mwema.
Thank you, Mbao.